Welcome to the Grow Your Practice podcast. Hi, I'm your host, Chad Madden, owner of Madden Physical Therapy and Breakthrough. Join me each week as we dive into the best practices, systems, principles, tips, and tricks to help you grow your private practice. Everybody that is logging on right now, if you could go to the chat, share your name, your practice location, and how long you've been in private practice, that would be great. I'll go first, then we'll have Mary go next. Chad Madden with Madden and Gilbert PT. We're in Harrisburg, Pennsylvania, and I've been in private practice for 21 years.
I'm Mary Daulong, and if I tell you I had been a PT for over 5 decades, I don't want y'all to think I'm old. I just started very young. I'm based in Houston. I'm the CEO of Business and Clinical Management Services, your premier compliance program provider.
In the chat also, once you've introduced yourself, and just type in what's the number one challenge that you're facing today in your practice. We'll catch up here a little bit. Melissa Shea, 12 years in Washington. Sarah Martin, Michelle Davis, East Coast, 16 years. Jody in Fort Wayne. Julie, Waco, Texas, 4 years. Kim in Chicago, 25 and a half years. Michelle Milan with Hayes PT. Hey. And Paoli. What's up, Michelle? Ashley in South Carolina. Sherry Prince, Omaha, Nebraska, 3 years. Great. Scott Gardner is here. Awesome, Scott. Just on the podcast.
Hi, Scott.
Nolan Esparza from
I'm
Sills,
seeing
Texas.
a lot of names.
Yeah. Sarah Lusk, in Alabama, 22 years. Heather Reeves, Columbia, South Carolina, 23 years. Jenna Boyd, Jody Ferguson, Nebraska. I almost said New England. It's great. 3 and 4 years. Awesome. Lots of people in here. Hey, there's Kellen and Blaine. Awesome. All right. So challenges, we have hiring, reimbursement and hiring, not trusting the process. Ooh, Kim, would love to know what you mean there. Site neutral payment, reimbursement, hiring, PTs finishing their notes, reimbursement, declining revenue, hiring, CHTs and authorizations increasing, making sure all claims with Medicare are paid. Hi, Sarah. Lengthy pre-authorizations, reimbursement decline, lose here. Awesome. Adequate reimbursement with insurance. All right. We have 47 more messages for me to catch up on. We're going to go to the next one. And what's the number one thing that you want to get out of the session today? Mary's going to be going over the 2025 final ruling with us, and we're going to talk about implications of what that means for our practice. But yeah, you can go to the chat again. What's the number one thing that you want to get out? And then we're going to get started here. All right. So for you, you're in the right place. If you're a practice owner, you're frustrated with declining reimbursements. We'll take a look at some numbers here in a second about what this means for us with another cut coming. You're already struggling with slim profit margins, rising cost, and staffing challenges. I know we just lost quite a few clinicians here within the last 6 months. You want to educate yourself. And I know many of you are in that same boat. You want to educate yourself and you want to learn what you can do to mitigate the risk and increase profitability. All right. And in the next 60 to 75 minutes in our time together here, we're going to get crystal clear with Mary. She's going to share with you exactly the pros and cons of what has come out and what this means for our profession over the next 12 months. And I'll go through 12 proven strategies that owners are doing right now to increase their profitability in spite of those declining reimbursements. And then we'll share tools with you here at the end. With BCMS, as always in my intro with Mary, from my personal experience, so what's the right way to say that? Mary's been to this office that I'm standing in right now with her team, Alicia and Teresa and the rest of the BCMS team. And we worked with BCMS compliance a few years ago now, but we had our second Medicare audit. And if you've ever been through that, it can be a fairly nerve-wracking process. And ours was probably maybe 12 to 24 months after Mary was in and educated all of our staff, and we went through an audit and everything else. And I remember at the time, and Mary and I can laugh about it now, but probably was a little worked up when we were making the changes, but we wanted to be, compliant, and we were taking a look at this. In the end, Mary and the BCMS team, they found that we had done a little bit of underbilling and leaving some money on the table. So they were able to find that for us, increase our revenue per visit. And the other thing that happened is when we went through the audit, Medicare actually wrote us a check for more money. So we didn't have to pay anything back. We actually got money back from Medicare, which is, I think it's fairly rare. And I know that there was a 0% chance that happens unless we had Mary and the team here. So that's what they represented to me. They keep us legal, compliant, everything else that we need to keep our money safe and our financial stability safe. So thanks for doing this, Mary.
My pleasure. And what he didn't tell you is when I was doing my education with his staff and he was there, that he kept sliding further down in his seat, like, if I slide out, this doesn't apply, right?
I have no idea what you're talking about, Mary.
Oh, yeah. Okay, so what is new in 2025 as it relates to the physician fee schedule? And as usual, there are wins and losses. This time, while we're still losing money, I think there's a potential benefit deception. And if you wait into the last couple of slides that I'll do, you'll understand what I'm talking about. So we're going to get to the hard, just right to the numbers right now. The conversion factor this year is 32, 35. That's the multiple of the RVUs, and that's how we get how much we're going to be paid. It's a decrease of 94 cents. When I was kind of looking at this, I said, oh, it's a decrease of almost $1. No, those extra 6 cents count. So I decided to make sure it was specific. The KX threshold is 2410 for calendar year 2020. PTs and speech and language pathologists still split that, while the OTs, lucky you, have it as solo practitioner. The manual medical review threshold remains at 3,000. And that's just as the KX threshold is split with PT and applies only to OT. That 3,000 is only to OTs. It's important for you to know that that is not like the way the RAC used to do it. That 3,000, yes, is something that puts everyone on the radar. However, there's other information that Medicare is looking for. They're looking for aberrant billing, something outside of the normal ranges for your peers, whether that's local, state, or national. So they're looking for abnormalities in addition to exceeding the 3,000 threshold. One thing we have not seen in audits, we've seen a lot of audits recently, a lot of call for records, especially from the supplemental medical review contractor. But we have not seen any specific to exceeding the $3,000 threshold. And my guess is, since they weren't enlightened enough to add a modifier for maintenance therapy, they have to guess. Is this because they have a legitimate skilled maintenance patient, or is this just routine? Because they don't have any way of knowing that without some type of indicator on the claim. And just for your knowledge, the Medicare beneficiary deductible went up to $257, which is an increase of $17. So we talked last year, actually in July, about misvalued codes. And last year we talked about misvalued codes. Well, CMS did meet in January, and they look at the codes used by therapists primarily from a possible exemption from practice expense labor calculator. And they were supposed to look at whether multiple procedure payment reduction was incorrectly applied. So they go in and they say, well, we made some adjustments, but we didn't have enough information. And so we'll have to review the implication of MPPR. That was the purpose, I thought, of the review. However, they did make some positive adjustments, so that's good for us. We don't have enough time in this session to tell you about it. And of course, those dollars are going to vary based on locality, your geographic index, that type of thing. But you can see we do have some codes that we routinely use: therapeutic exercise, aquatics, gait training, manual therapy, and so on. But look at the negative adjustments: neuromuscular and therapeutic activity. So both of those had a reduction, and we don't know exactly what the reduction is. I have not been able to ascertain that information. It just, they keep adding information. In fact, a few minutes ago, I was just updating a slide because I was able to find more information. But I don't think that they are major modifications, but they, and when it's a reduction, it's a reduction. Okay, let's go to the next slide. So here's a good one. This is a positive. The supervision of the PTAs and the OTAs did get approved effective January 1st. So all settings, including private practice and Part B home-based services, will be able to use the general supervision definition provided by Medicare. Now, I'm showing you a physical therapy general supervision definition. This applies to most practice acts in the United States, and it is the one that the Federation of State Board uses. So it's pretty applicable to us. It varies some from OT. And basically what it says is that the supervisor is scheduled to be available. That means if there was ever a question, that person's name needs to be on the schedule, attendance schedule, so that it proves that they were available. This is not cherry picking what supervisor might be there. So you want to make sure that there is a scheduled supervisor noted and that you're able to get to that person's name if ever you had to validate that. The supervising therapist is to be on call and readily available physically or through direct telecommunications to talk to the assistant, to give them written or oral instructions. And it is based, of course, on a plan of care. There should be something in place in policy for predetermined plans for emergency in the event that supervising therapist is not available. So there should be a way to designate an alternative in the absence of that. Now, if your state does not recognize general supervision, you need to be cognizant of what it states and what it limits. Medicare does not trump a law that is more restrictive. So if your law does not allow for general supervision, you have to comply with it for all payers and as well as Medicare. For occupational therapy, their general supervision, and again, it varies very widely. They don't have a national body like the Federation to go to for kind of a umbrella definition. Some states provide the supervisor and the supervisee to work together and design a supervision plan. Other states are very specific and they dictate frequency, the nature of the supervision. And so again, you need to be aware of your law. Someone just asked if there is a reference place on where we can pull our state information. And if you contact us, our information's on the back, please put webinar question and ask that, and we can get that information to you. So the bottom line is that you need to make certain that you know your state laws. Okay, so let's go. Okay, I don't really think this is going to happen, but according to the rules, we don't have eligibility for telehealth starting January 1st, 2025. So they did not, because it takes congressional action to put us on the list of eligible providers of telehealth. There has not been congressional action However, and this is why I say I think there will be a move to make sure that we at least get an extension. I don't know that we'll have a vote that we will be eligible providers, but maybe an extension for another year or two, because Medicare stated in the final rules that they have the right to make exception and to expand the scope and access of telehealth services. If there is congressional action and they make therapy providers eligible as providers of telehealth, then we would be able to use the new provision for interactive telehealth communication. So that means two-way, real-time audio only. If we have an extension of our telehealth privileges, but not eligible as noted in law, we will have to see whether they're going to make us eligible for that or not. This is for providing services to beneficiaries in their home. If the distance site practitioner is technically capable of, I guess that means using a phone, which I would hope we are, and the patient declines or is not able to use a phone, then, to use video, then that telecommunication system will be allowable. Okay, next slide. Okay, caregiver training and education codes. This is the one I updated just a few minutes ago. It is very difficult to understand why they keep putting the same codes in. We had 97550, 51, 52 available to us in 24. And finally, about an hour ago, I found out why, and this was to illustrate that those codes, even though they exist and they haven't changed in any way, they are eligible to be used via telehealth. As you see, we have a new code, 96202. It's up to 60 minutes, and this is for group training in behavior management or modification for patients with mental or physical health diagnosis. And really, this is kind of based on them really looking at direct care services and support for patients that need that direct education. They're using examples like techniques to prevent decubitus ulcers, wound care, infection control. Well, we do all of that. We don't do it as a nurse would do, but as far as like decubitus ulcer formation, I would say if we're teaching a patient how to properly be positioned, or how often they get up and sit versus lying down, those types of things, this might be a tool that you would use. And finally, they did add 3 more codes, geo codes, so those are temporary codes. And what they say, these are direct care strategies for patients with ongoing conditions and illnesses with the intention of reducing complications. So that's how it ties into those direct care services. And also, you're supposed to use this code to indicate verbal consent for the use of telehealth. Okay, we can go to the next one.
Mary, I have a question.
Sure.
And there's one in the chat as well. But so these new codes will be telehealth eligible. On the previous slide, it was basically the way that it looks now is we're going to lose telehealth.
Yes, but I'm saying if we can't use telehealth. That's why I said eligible, but it's provisional. So if we lose telehealth, we will not be able to do caregiver training via telehealth, because as you remember, these codes were set up to be face to face.
Yeah.
So that will be the major change.
Got it. And then the other question that we had from Dave was, for the telehealth slide, does that apply to physical therapy, occupational therapy, speech, behavioral health, all of the above, or are they
us? And I don't know about behavioral health. I do know we are specifically not the 3 therapies, so PT, OT, and speech and language, are not approved telehealth provider
Okay,
you know, from a legal perspective.
all right. Thanks for clearing that up.
Okay. They tweaked remote therapeutic monitoring codes, and I have very little information on this, but they were revised in September. I have researched this, probably not as much as you guys who have RTM services, but basically the new code 98975, well, it's not a new code, excuse me, it was updated to clarify that you could use that code to instruct the patient on the use of an application or the platform. So the setup, the use, that type of thing. I guess there must have been a lot of questions about, was it just setting up the device or did it include instruction? And it does. And this last bullet, these two codes were revised to include device supplies for data access or transmission to support RTM with patients. And I can't get any finite information on that. So look for that to come possibly in a SIPA or something of that nature. So if the patient is present, then we cannot use caregiver codes. That is correct. Caregiver codes are only for situations in which the patient is not present. It is communication, education with the caregiver, either as a group of caregivers or individual caregivers. Okay, so there's a lot on MIPS and way too much to cover. I'm seeing lots of questions coming in, so I'm probably going to answer them right at the end. Is that okay, Chad? Okay. There's just so much on MIPS, and if you want something specific about it, please feel free to reach out to Jody Swearingen. He is our new Vice President of Client Compliance, and this is his email address. Please know that unless it's a very generic question, we do charge consultation for specific payment consultation.
Great.
Okay.
And I did put Jody's email address in the chat for everybody.
Perfect.
Get there.
What is MIPS? We'll get to those. I'm sorry. Okay. So let's talk about the plan of care. Okay, so everybody's jumping out of their skin and saying, yay, yay, we don't have to get a signed plan of care anymore. Well, that's not exactly right. But before we do that, I want to explain this. CMS has changed the term plan of care to plan of treatment. And for those of you who know me, I am very sensitive to terminology, very sensitive. For instance, we don't accept orders and we don't accept prescriptions. We accept referrals, and there is a significant difference. An order and prescription tells you precisely what to do and what is to be done by the person receiving that order or prescription. A referral is a request. There's a significant difference, and it's listed in most, if not all, practice acts. The way we receive patients from outside sources is via a referral. So I'm saying that at the beginning. So now with the plan of care, it was basically stated, and it's, if you're interested in this, you can certainly go to the unpublished version of the 2025 final rules, and we can certainly make that available for you to read the comments that are stakeholder comments. And if you don't have to read between the lines, it's very clear what some intentions are. So the plan of care, again, is patient-centered with the physician and the non-physician practitioner at the helm, while the plan of treatment is more narrow and specific to therapy services. So what this states is the establishment of the plan, and this is, you know, when we get into the plan of treatment information and the signatures for certification, they state the establishment of the plan is to be established before treatment's begun. Now, you don't have to write it if you are going to treat the patient same day that you evaluate them. But you do have to have it in some retrievable form before any elements of the services are delegated to another person or performed by another person. So it says a plan of care can be established by a physician, a therapist, a physical therapist, a speech and language pathologist, occupational therapist, nurse practitioner, clinical nurse specialist, or physician assistant. I always wonder how 1, 4, and 5 know what we need to do to the patient. But that's my position. So the content of the plan of care, again, and this is from the document, the plan prescribes the type, amount, frequency, and duration of physical therapy, occupational therapy, and speech and language pathology services to be furnished to the individual, and indicates the diagnosis and anticipated goals. So you see that word prescribe. Again, that's a source of irritation, but if we're writing it, that's well and fine. But if we're not writing it and it is prescribed, we lose that evaluate and treat type of behavior and involvement with the other medical professionals we work with. Okay, let's go to the next slide. So the certification that everyone is excited about is, these are your options. If you have a written order, you see the word order, and this is in the final rules, is the source of an initial visit, the therapist no longer have to obtain a signed plan of care for the initial certification period. And additional or subsequent recertifications do require a signed plan of care. The therapist must generate the plan of care, so you have to write it, you have to send it to the physician or the non-physician practitioner within 30 days of the initial visit. You have to retain proof of transmitting the plan in the event that there is a question about that, or you have to validate that. For instance, if you were audited, that would be a source of validating that. The physician can change the plan at any time. Now that's a problem. You develop a plan of care, you send it on to the doctor, you don't receive a response, and then somewhere down the road, there is, hey, we didn't agree to this particular service or intervention or whatever. That could be problematic. But to address that, Medicare did state that CMS must pay for all services delivered if the plan is compliant and the services are medically necessary until the plan is altered by the MD or the NPP. And you know, I have rarely seen this happen. I've rarely seen a physician change a plan of care, at least not in the last 20 years. But I did recently, and not only, and this was prior to this coming out as a final rule, but had a therapist who was treating a patient under a plan of care that they sent to the doctor, and also under a referral, and the physician contacted the patient and told him to discontinue physical therapy. And they are still trying to get their money because they don't have a signed plan of care. So you have to be, you know, alert to this type of situation. Okay, let's go to, okay, here we go. So what this new option does, and this is my soapbox, so if y'all don't want to hear it, you can certainly just go get a glass of water or something, but in my opinion, it diminishes and it evaluates all the direct access accomplishments we have achieved over 3 or 4 decades. It emphasizes the word order, and again, that is not how we relate to other medical professionals. And it's problematic in that if you really look at the word order, we have to follow it exactly, and it allows very little latitude. It's a reestablish and inferred control of decision making. And because, as I said, it's instructions and specific action, while referral is a request. And the one that, of course, is somewhat concerning is it implies subserviency. So, which means you, according to the definition, that you will obey another unquestionably. So again, where is the clinical decision making? The autonomy we've had in that arena over the last 30 or 40 years, is it going to shrivel up, up when you decide that you're going to accept a referral just so that you don't have to get a plan of care signed? And finally, it does not remove the burden of recertifications requiring signatures. So if you have a plan of care that you've established under a referral, and that referral either has a date on it, which is different than the plan of care, there's always a question which one will supersede the other, and that date then becomes an issue as to whether you're going to recertify for 30, 40, 60, 90 days. You can't go past 90 days, but just remember that you will have to be able to keep those to the referral if they put a duration on it that does not coincide with the duration of your plan of care, because you have no signature to verify that they are in sync. Okay, next slide. So we have options and certainly recommendations. Now, I'm not shy about that, you know that. I consider this a bypass kind of, intervention, but I think it can have a very long-lasting impact on patient access and erode our legislative achievements. So please consider that. I understand I had a practice. I know what it's like to have to chase down plans of care. There are ways to handle those that don't sign timely or ever sign plans of care, and we'll be glad to share that with you. It relates to technical denials that can then convert to a patient responsibility, and how we can help you use that tool. You can voice your opinion to individuals and organizations that laud this as a step forward. I think people need to think about what we've achieved and what we might lose. We need to reach out to our legislators to get real relief from the requirements of certified plans of care, and eliminate, and there was a statement, and I will give credit to the associations that did bring this up, that said order should equal referral. But I'd like to see the words order, prescription, and scripts just removed from anything that we say as it relates to the patient services by qualified therapists.
Before we continue with this episode, here's a word about our course, Profitability Under Pressure.
How does your practice's profitability today compare to what it was back in 2019? Is it keeping pace with inflation? Hey, this is Chad Madden here. I want to introduce you to the Profitability Under Pressure program. This is a 90-day masterclass designed to help you build a robust financial system for your practice. Most owners aim to improve revenue per visit and enhance their bottom line. However, many are facing declining reimbursements and rising operational costs, making it challenging to maintain financial health. The Profitability Under Pressure program consolidates the best practices currently working for practice owners into one comprehensive system. This program will help you boost profit margins, reclaim your time, gain time freedom, and assist more people in your community and leave a bigger impact. You'll learn how to conduct a profit leak audit, create a profit plan, and use various levers to increase revenue. Additionally, you'll get a 90-day trial of our patient demand software, and access to our exclusive Inside Circle community. Here you can connect with other like-minded practice owners who are navigating similar challenges and finding solutions. Don't just take our word for it. Hear from owners like Lance Gross, who added $1.1 million to his bottom line, Peg Gray, who got her finances under control, and Jeff Gersh, who saved time with our cheat sheet for increasing profitability. Don't miss this opportunity. Apply today for the Profitability Under Pressure program and start increasing your profits by $10,000 or more within just 90 days of implementation, guaranteed. Secure a more stable financial future for your practice. Click below and apply now to join the ranks of successful physical therapy private practice owners who transform their businesses with our program. Apply today.
Thank you for listening this far. Now back to the episode.
Yeah, we'll have time for questions. We can take, I see two here in the Q&A. Let's go through those.
Yeah.
I've heard that we can't use the caregiver code if the caregiver is paid, meaning direct support professional, Medicaid worker, etc. Is this true?
That is correct. These are to be family members, neighbors, volunteers.
Great. Next one is, when is the plan of care or plan of treatment considered finished? Thinking of RTM and not being able to bill if the plan of care is over.
Wow, I have to think about that one.
Yeah, that's
Yeah, okay. Still, speaker. Okay, you did it.
I'm wondering that too, if there are implications of the telehealth. But yeah, that is a great question.
That is an excellent question, and I
Yeah.
don't have the answer, but I will certainly research it.
Yeah, great. And then Andreas has another one here. What do you do with an order that says evaluate and treat?
A referral that says evaluate and treat?
Yeah.
What do you mean? What do you do? I mean, I guess you can you put it in your file and write a plan of care exactly the way you think it is best for the patient to achieve the goals, the functional goals that they need to achieve, and send it for signature. The new provision does not require you to use it. I would request and recommend that you never use it as that tool. Medicare still has in their benefit policy manual that Medicare does not require a referral or an order, but rather acknowledges the plan of care as the source for payment authorization.
Great. And then we will put this as well in the chat. There's a poll coming up on your screen for compliance program review with Mary and Alicia and Jody, the team at BCMS. Free compliance program overview. Stay safe with your financial health of your practice. Click yes for that. And you crushed it, Mary. Thanks. And we'll come back here for more questions as well.
Okay, that sounds great.
All right. So last year, what does this mean for us as a practice owner? And just out of curiosity, yeah, okay. If you were on last year, we talked about Medicare conversion factor from 2008 through 2024 this year. And the one thing that I had shared is the conversion factor in 2024, it's below where we were in 1994 with no adjustment for inflation. And that creates a bit of a problem for us. So I just went to cms.gov. Anybody can do this. I looked at the physician fee schedule and mapped out the conversion factor since 2008. Is this getting better, staying the same, or getting worse? I'd say it's going down. It's very clearly trending in the wrong way. If for most of us, we look at inflation, and I'll call out Scott Gardner here in the UPTA group, looking at that, and it's very easy to look at inflation numbers like this, like, how are we doing relative to inflation? Fed, the goal is 2% per year in terms of inflation. We look at something like this and we're thinking, okay, I'm going to be okay, right, with inflation. And the problem is that we're not thinking about cumulative inflation, because this adds up over time. So for example, since 1994, off the top of my head, I know from 1994 to today, inflation is over 100%, right? So $1 in 1994 is worth about 48 cents today. And if we just go the last 5 years since 2019, costs are up 32.5% as a result of inflation, primarily from the dramatic printing of money from the pandemic. And by the way, this is government fact. This is not, we're not doing conspiracy theory. This is really happening, right? And we're feeling the effects of that. So we have this cumulative inflation that has happened over time. And this is what it really looks like. So the blue line is that CMS or the physician fee schedule. The green line is the cumulative effect of inflation. So if we go back to 2008 and we have, and the physician fee schedule scale is kind of funny, so I had to roll with it. But if you go and you look at, the blue line represents our income reimbursement with CMS, right? Anything that uses the physician fee schedule. And the green line represents our costs. What's the difference between the blue and the green line? What would you call that? You can just type that in the chat right now. What's the difference between the blue and the green line? What would you call that? Income minus expense is what? Profit. Lou says profit. Profitability margin. Right. So it's profit margin, margin of safety, whatever you want to call it. That's where we were 15, 16 years ago. Right. And then what is happening is that margin is narrowing fairly quickly. And, so just think about how this affects us. How does it affect you if you're doing admin work, right? If you're involved in billing, office management, et cetera, for private practice? How does it affect you as a clinician? How does it affect you if you're a director of a private practice clinic? And what about the owner? So just out of curiosity, whatever your role is within the practice, if you're administrative, you're going to type A, staff clinician, just type S, director, type D, and owner, type O, and just go to the chat. And what are you relative to the practice? So Daniel. So it looks like all administrative owner, one director. The rest is all of the above. Okay, got it. So it affects each of us in a slightly different way, right? If you're an owner, you're thinking, well, probably something around risk reward. Like, is this worth it? I heard that within the last 5 business days twice from 2 different owners in different areas of the country. Is this like, these are the trends, is this worth it, right? Like that is an actual consideration. From staff, I hear, how can I be more valuable, right? My costs are going up. I used to walk out of the store with $100 in groceries. Now that's $200 after just a few years. I'm getting beat up here. How can I be more valuable to the company so that I have more stability? If you're admin, you're looking for that stability, safety as well within your role. And just think, whatever your role is, how is this affecting your team, right? How is it affecting your ability to deliver care? I know Mary and I have talked in the past about, access to care being a really big deal, especially for legislators and their constituents, that if we're under that much pressure in terms of profitability and just keeping our doors open, that is something that speaks to legislators, that access to care. What does this mean for your practice and the challenges it's causing there? What does it mean for your community and your ability to, leave an impact there and provide service and help? And then also your family and ultimately you as well. And, here's some of what we're hearing from owners. The big theme that I'm hearing is like, I don't want to play the volume game. It's impossible to do that today, like we could do 20, 30, 40 years ago, right? I mean, I know practices, and I was in a situation early where I think between myself and a PTA, we would do 30 plus visits in a day. Those days are long gone, right? So we're in this ethical dilemma. We can see a higher volume, maybe, right? But little dicey to do that. That's not what we want to do. That's not how we're wired, but that would compromise our quality of care, which is really important to us, right? So how do we make ends meet here? And we're going to talk through that as well. Last year, I shared this diagram, a little bit easier way to look at it this year. We've modified it now. We've worked with a lot of practice owners around this, creating profitability in spite of everything that's happening. And it's this, we're going to take a look at this over the next few minutes. So the first thing is on this, you'll see is audit. That's looking. I'll go into that here in a second. The next thing is creating a plan. And then step number 3 is strategizing. I'll run through those right now, but we basically see 12 strategies that are working right now for practice owners to improve their profitability, to improve their margin of safety, and move in the right direction. So whether you're an admin and you're trying to create a stable work environment within your private practice, or you're an owner and you're looking for that same thing, create a margin of safety, take better care of your team, and continue to grow and expand and leave a bigger impact in helping people, then that's what we want to do. So if we talk about the profit leak audit, we started sharing this a little over a year ago. Lance Gross, owner in Arkansas, went through the profit leak audit. It was, per Lance, it was worth over $1 million to his practice. Pretty cool story. He shared that at one of our events in Orlando in January. And then Dave Bender heard that story, went back to his practice in Baltimore, Maryland, did the same exact exercise. And this is something that every single one of you can do and should do to take a look at what's happening with your revenue, right? Every practice is different. And this goes beyond looking at just income or revenue per visit, but taking a look at an actual patient and seeing what you're reimbursed, what the codes are being reimbursed for as well. So that's number 1, is we want to take a look at what's going on with our revenue, with our profitability. Number 2 is we need to create a plan. Best case scenario there, Mike Hyde, he was on the podcast, Grow Your Practice Live podcast as well. Mike did an amazing job, took over a practice, pretty unique story, and they were looking at how to improve profitability. And in Mike's case, it was increasing patient visits in an ethical way and filling not only his schedule, but the other clinicians' schedule, and ultimately filling their space. But the way that he got to that point was by first creating a financial plan for his practice. And the third step here is the strategies, and there are lots. I'm going to go through the 12 profit levers. If we have time, I'll run through one of these right now for you, just how you can apply it. But we have, the first one is what we see owners doing all over the country that more than once is working, right? So and these are the 12. So reactivate best payers, right? So you can, for example, go through your EMR. Every one of you probably knows who your best payer is, and you probably know who your worst payer is, right? You can go through and do one-on-one reactivate with your best payers, right? The second thing that we see working really well is reactivating best payers with campaigns, email, direct mail, text. Third thing you can do that we see working is you can attract best payers with partners. Quick, easy exercise. Who are the top 10 employers in your area that offer the best paying, best reimbursing insurance to their employees? You should know who they are, right? And then you can create relationships there where you're ultimately, that employer is promoting you to their employees. 4, what we see working, attracting best payers with cold traffic. We run lots of different funnels here, and not only in my private practice, but other practices as well. Bringing a pelvic floor patient in is a lot different than bringing a rotator cuff patient in. You should have an idea, right? And we're now at the point where we have to start paying attention, because the average profitability in private practice is less than 10. And that's it's fairly thin ice to skate on. 3 ways, number 5 here is 3 different ways to introduce add-on cash-based services. 10 years ago, when we started talking about this, nobody in our industry was doing this, right? This is not happening to us. Yes, reimbursements have gone down the last 5 or 6 years, but this isn't going to continue. Well, now it's continued for 10 more years, right? It's time for us to start thinking outside the box a little bit. And there's lots of examples here when adding cash-based services. Increasing graduation rate with 7-step exam. We work hard to bring a patient in and there's drop off and they're not completing their plan of care. That reflects on us poorly over time as an industry, and increasing graduation rate is an easy differentiator for your practice. Recheck days, something that is legal, compliant, ethical. When a patient graduates their plan of care, to have a recheck day in the future. We see lots of practices doing this with great success. Dropping the lowest payer, something very straightforward to do. We featured it on the podcast as well. Bob Kowalik has done an amazing training for us here at Breakthrough around how to do that, going through dropping the lowest payer. You can renegotiate rates. I know many of you probably already have this, but we have a workbook on renegotiating rates. Yeah, so we have the this workbook right here that Tony and Melissa Sear, went through. They started renegotiating rates back in 2020. Many of us think that we're too small to do that. They were amazingly successful at Kinetics PT in Florida. And then they went through, we worked with a professional copywriter. We worked with AI as well to create a template that now other owners are using and they're going through and renegotiating their rates as well. Scheduling, we can start playing practice math. 1 hour might be appropriate for your practice. You might be leaving a lot of money on the table. And in particular, you might be billing for services that you're never going to be reimbursed for at that hour. So walking through that, we see a lot of owners taking a look at that. Stop underbilling. Prediction Health, number one mistake that we make, right? And billing that AI is finding is we're rendering services that we don't bill for. And then the other one is going through, Mary does the skill progression. She has done training for us as well. That is amazing, helping owners thinking through skilled progression and demonstrating that within their note and also their billing, and then incorporating the 3 phases of healing that maximizes our skills as a profession. So, and, full return to function, everything else. So Sean Weatherston, practice owner we've worked with for years in Idaho, more than doubled his visits by going through implementing these same exact processes. The big thing here is Sean was on the podcast, shared how he went out of network with UHC. Varel, another big success story here. Varel raced out of the gates, went from $83 a visit to $98 a visit and did that in less than 3 months. I mentioned Tony and his wife Melissa before in terms of renegotiating rates. Not only have they done that, since we started working together, they've more than tripled the revenue in their practice. And this year alone, and just at our last event here in Denver, Tony was there, shared that they are on track. They're ahead of pace to do more than $500,000 this year in add-on cash-based services as well. Pretty cool stuff. So we have a program here. I want to leave some time for questions as well. So we're going to go through this, but we have a program called Profitability Under Pressure. It's a 13-week masterclass where we go through each one of these steps. I'll show you this. I'm going to exit my screen really quick here and just show you one thing. All right, so everybody should be able to see my screen here in 1 second. Great, so just wanted to show you this. With our program, we have lots of pre-recorded material, including Mary's training, including Bob's training, including renegotiating rates. That is in here. The one kind of crazy thing is all the information that is in here on adding cash-based services. So this is what is working for practice owners right now. We have everything from conversion in here to dropping a lowest payer to facility. What can your clinicians do when there's a gap in their schedule? Financial health, going through the Profit Leak audit, going through the profit planner as well, goal setting for your practice for the year, going through hiring. I know this is probably the biggest button that I've heard at the last few association meetings that I've been to is we can't hire, we can't find anybody. In fact, the call that I was on, the implementation call I was on right before this, an owner said, we finally got somebody after 3 years of looking. We're finally hiring another clinician. Marketing, tons of stuff on marketing in here, especially marketing for profitability and a lot of other goodies, renegotiating rates, software optimization, going through workshops if you're hosting workshops as well. So all of this is included within the program. And the way that it is set up is what we do is we not only go through every week, we go through material and then we go through an implementation call. So ideally for practice owners that are looking to implement, that is, there we go. This is ideal for owners that are looking to implement these strategies and get them into your practice. Here's the deal. Every practice is different, and we teach all 12 strategies because what works for you in Idaho might not work for that owner in Florida, might not work for that owner in Boston. So everybody's different. And how we teach is you want to move 1 or 2 things per quarter in the right direction, right? And that's about all that we have the capacity to do. Most of us are time starved. So within the program, Mary's here. Paul has done training that's in there as well. Bob Kowalik, Tony Sear, Mark Callanan, Tyson on, online advertising. It's for you if you're a private practice owner, you're feeling the pressure, you see the trends, you want to learn. And really, here's the big deal. You can take action. You can implement. I love to work with owners. I love to share with owners best practices that are going to take it and implement and get wins as well. Yeah, Mary did an amazing training in there, strategic coding and telling the story on the claim. Beautiful. I think it's 75 minutes, chock full of information, how you can, use strategic coding, make sure you're not leaving money on the table as well. In addition, with the program, you get Breakthrough Pro, which is the same marketing software that I use in my practice. It includes pre-built campaigns, both for text, email, etc. And to apply for the program, you have to apply. Just go to getbreakthrough.com/BCMS. It's getbreakthrough.com/BCMS. You're going to fill out a short application. Should take you about 2 minutes. And then you're going to choose a time to schedule your application review with a member of my team. Right now, we have 37 owners in this class. Absolutely amazing group. We're about to wrap that up and start a new class here as well. So with regards to time, now is the right time to apply and hit 2025, hit the ground running here in 2025. Lots of reasons owners are joining the program. The biggest one is we're hitting that critical, crisis of meaning moment where reimbursements are declining, costs to provide care are going up. I know we just lost a clinician, amazing clinician to the hospital system here locally. They're offering $15,000 sign-on bonuses, and that's very difficult for us to compete with. So, many of you are in that same exact situation. And if you're looking to compete, create some stability for your practice. We have the program where you take a look at your revenue, you create a plan, and then you implement one of those 12 strategies. The other thing is most of us are time starved. And every once in a while, I'll talk with an owner who says, I'm going to figure this out on my own. That's fine. But you're probably wasting time that you don't have, right? If we're time starved, we want that shortcut. And you get this all without having to reinvent the wheel on your own, because we're going out. I get to cheat. I get to go out and find best practices and bring them to you. So think through, what would this mean for your practice? Again, that link is getbreakthrough.com/BCMS. You can go there right now. Very straightforward application. I can show you that. And we're going to open this up for questions while I do that. We do have 2 pre-submitted questions here, Mary, that I'm going to go to next. 1 second. All right. So that application, the getbreakthrough.com/BCMS, will take you to a page like this. There's a short video here for you to watch. Just click apply now, and you're going to complete this. Again, should take you about 2 minutes. Click apply now. It'll take you to another page to schedule your application review with our team. We're going to make sure you're a private practice owner, that is going to benefit from the course and that you're going to take action as well. It'll be a short call, but then after that, you'll be invited to enroll in the program. All right. So our questions, pre-submitted questions. All right. First one is, we have been working on negotiating rates with insurance companies, and part of that negotiation is for payers to fund for missed visits or no-shows. Many of the no-shows we experience are families who are on Medicare, and would love some insight on if this will be addressed in the near future with Medicare. Along the same lines, how to bill for time spent when families pick up their child late. Any comment on that, Mary?
Sorry, I was typing. Say it again.
Oh, sorry.
I was answering a question.
Yeah, we've been working on negotiating rates with insurance companies, and part of that negotiation is for payers to fund for missed visits or no-shows. Many of the no-shows we experience are families who are on Medicare, and would love some insight on if this will be addressed in the near future with Medicare. Also, along those same lines, how to bill for time spent when families pick up their child. I don't know of anything addressing that in any way.
As far as picking up your children, I have no idea that would be payable at all. As far as no-shows and cancellations, Medicare does allow a direct pay for cancellations and no-shows from Medicare patients. They do not reimburse, do not pay for that at all. If it's
Okay.
other payers, that's going to vary by policy and plan.
Next question. I have a question about scheduling 2 Medicare patients in 1 hour. Can I bill 38 minutes for one patient I spent 38 minutes with and a second patient for 23 minutes for a total? I'm guessing that's okay, for a total of 61 minutes, provided I do not start my next patient until 1 minute past the next hour. If one cancels or no shows, I see the one patient 53 minutes and bill 4 units.
Okay, so for specific management of how you're going to time things and code for them, be glad to consult with you. The one thing that you have to remember is with Medicare, now if these are 2 Medicare patients, they're both under the 8-minute rule, so you're going to use the total one-on-one time, but are you implying there's no other time that you're working with those patients? So is that 38 minutes timed, or is that 38 minutes plus other interventions? So without knowing those details, it would, not behoove us to go into detail and, discuss what the terms of the situation are. But I'll be glad to, if you will formulate the question, I'll be glad to answer it by email if possible.
Awesome. Have it pay, create a policy for paying for pickup kids late, just like childcare. All right. So do you want to answer John's question live? I'm looking at a referral that is titled referral order. What does that mean?
I did write an answer. That's what I was doing.
Okay.
And basically, in the Medicare fee schedule, it stated the header was with an order. And then as you go through the text of this, it will say clarification, order equals referral. Well, if you look up the definitions, they are not the same, but they are saying they will accept them as the same thing. So if you have an order or if you have a referral, then you certainly are eligible for this bypass of the certified plan of care. But again, Medicare does not require either for payment. They require a signed plan of care unless this new provision is in place, and that is a provision to have a referral, and it only applies to the initial certification.
Got it. Thanks, Mary. Next question from Brittany. How long does it take for the misvalued CPT codes to be reviewed? When will we find out how much they've been adjusted?
Oh, I don't know where the numbers are. I understood they were supposed to come out in December, so we should be able to see that. So if you go to the fee schedule calculators for your max, they should have those adjusted amounts in there. I don't know, with everything that's happening in the government right now, I was surprised that the fee schedule came out November 1st. So maybe they're working hard to get this done, but they have the numbers. They just have to process it. They know what reductions and increases they've made.
I think caught up on the reimbursement questions. While we're here, how about some love for Mary in the chat, bringing us the mixed news every year in such a delightful way.
And I had someone ask about the link to the unpublished, and when I say unpublished version of the final rule, it is the final rule, but it has comments. You can go to the Federal Register for the published version to see just the outcome. And I put it in the chat box, the link.
Awesome. So lots of love for you. Yeah, a lot of exclamation points and all caps. Shout outs there, Mary. Love what you're doing. Thank you so much for keeping us compliant and moving in the right direction here, letting us know what's in store for us. Thanks.
Well, we would sure like to work with everybody to help them be compliant. And there is an opportunity to still be profitable and be compliant.
Yep. This just came in. It was a good question. How do we get in touch with Mary to see about a clinic compliance review? So Kimberly, you can either answer yes in the poll that came up, or if that's no longer available to you, we will repost right now. Alicia's the main contact, right? Mary?
Right, it's at the end of the slides, her contact information.
Yeah, we'll repost it here. And then, yeah, for everybody that registered for this, we'll be sending out a replay as well. Yeah, let me just grab that really quick. While we have that, one more question came in. Oh, there, Mary's email is in the chat right now for you, Kimberly. Which rule do we have to follow for Advantage Care plans, the 8-minute rule or the AMA?
Okay, you hate the answer, but it varies. It's based on the plan. The plans often will use the 8-minute rule, but they don't have to, and they can utilize the AMA rule. The thing I want to remind you is if the plan is silent about which coding methodology they use, defer to the 8-minute rule, because these patients switch plans, go back to traditional, and we run into the same problem over and over about this. You know, they switched, they didn't tell us. So as a reminder, January 1st, ask all your patients if your benefits are the same.
Yeah, truth. Great. Well, Mary, always delightful to do this with you. Thank you again for everything that you do in private practice. And thank you, everybody that's still on here, for putting in the work in private practice. I know you're in the trenches with us here and solving problems. So thanks, everybody.
How does your practice's profitability today compare to what it was back in 2019? Is it keeping pace with inflation? Hey, this is Chad Madden here. I want to introduce you to the Profitability Under Pressure program. This is a 90-day masterclass designed to help you build a robust financial system for your practice. Most owners aim to improve revenue per visit and enhance their bottom line. However, many are facing declining reimbursements and rising operational costs, making it challenging to maintain financial health. The Profitability Under Pressure program consolidates the best practices currently working for practice owners into one comprehensive system. This program will help you boost profit margins, reclaim your time, gain time freedom, and assist more people in your community and leave a bigger impact. You'll learn how to conduct a profit leak audit, create a profit plan, and use various levers to increase revenue. Additionally, you'll get a 90-day trial of our patient demand software and access to our exclusive Inside Circle community. Here you can connect with other like-minded practice owners who are navigating similar challenges and finding solutions. Don't just take our word for it. Hear from owners like Lance Gross, who added $1.1 million to his bottom line, Peg Gray, who got her finances under control, and Jeff Gersh, who saved time with our cheat sheet for increasing profitability. Don't miss this opportunity. Apply today for the Profitability Under Pressure program and start increasing your profits by $10,000 or more within just 90 days of implementation, guaranteed. Secure a more stable financial future for your practice. Click below and apply now to join the ranks of successful physical therapy private practice owners who transform their businesses with our program. Apply today